Good afternoon, everybody. Oh, can you hear me? Does that work? It's a pleasure to be here this afternoon, and I was only here this afternoon. I didn't get to hear the morning sessions, but I just want to show you the thoughts I've been having in just the last hour and a half. Since John and Kathy and Becky approached me about this, I've been thinking a lot about the relationship between Medicaid and palliative care. And I am from Medicaid, so I work in the part of HHS that focuses on the Medicaid program, and particularly around services for people with disabilities. So as I was thinking about this and listening to the conversation this afternoon, I was struck by what I would call common themes between palliative care and the Medicaid program that I believe is the Medicaid program of the future. And remember, Medicaid's been around since the mid-'60s. It's in statute, it's a very old program, and that causes us some problems sometimes. But what I came to the same conclusion that Mike did, which is that the approach of palliative care is relevant to the entire lifespan. It's relevant to the entire approach for care within the Medicaid program. And here's what I mean. The Medicaid program, as you know, pays for a list of services that are called out in the Social Security Act. There's a list in the law, and you can go to the law and it says, we'll pay for this. States have to pay for these services. They're mandatory, but there's a whole list over here of what we call optional services. States can pay for those or choose not to pay for those. A mandatory service is nursing home care. So if a state has a Medicaid program, it must pay for nursing home care for people who are eligible. There's another group of optional services called home and community-based services. They are not mandatory. They are optional. And I see such commonality between the palliative care approach and the approach to services in what's called the home and community-based services program. And let me tell you some of the similar values and themes I heard just this afternoon in the last 2 hours. I heard people talking about quality of life. I heard people talking about person-centeredness, people being in control of their own lives, their own plans of care, directing, self-managing. I heard a concern about reducing inappropriate institutional care, whether it's hospital, ER, because it's not in the best interest of the individual. It's not the right setting at all times for people to be served. I heard concepts about creating home. I heard self-management, self-direction, choice, supporting caregivers, meaningful life experiences, community, and I would add respect and dignity. And those are all fundamental principles in the Home and Community-Based Services program. Now, I don't want to suggest that that's a perfect program because it's not, but it's a program where I see the values of palliative care trying to be played out. There are over 1 million people in those programs across the states. There are something like 320 approved home and community-based services programs across the states, and they are for people who would otherwise need an institution as their primary provider of care. Think about that for a minute. We define people as needing institutional care. Not to me the way we should be defining when and how people need care. So we have been on a quest for literally about the last 7 years. And that's a little embarrassing to tell you that it takes us that long to do something in the federal government, but this was a challenge for us. And we were trying to figure out how to help define what it really means to provide services to people that are truly home and community-based under the Medicaid program. So we set out literally 6 or 7 years ago to develop a regulation. Probably not the best way to define a value system like home and community-based services, but it's the tool that the federal government has at its disposal. So we started down this path to try to define for states what constitutes home and community-based services, meaning Medicaid will pay for it if it meets those criteria. We'll still pay for institutional care, but we will not call institutional care home and community-based services unless it meets certain criterias. those criterias and characteristics I just described. So we have just published this rule. We actually managed to publish this rule as a final rule. It was published on January the 17th. We're now in the middle of a huge process of trying to communicate with the many, many different stakeholders out there who are impacted by this rule. But what it attempts to do is to try to define those characteristics that we believe represent home and community-based care for people with disabilities that Medicaid should be paying for. So I would invite you to take a look at that regulation. We have a lot of fact sheets on the website, and I have some material here I'm going to leave for you. But embedded within those regulations is also a definition of what we mean by person-centered care. And again, trying to define the boundaries of when someone is providing person-centered care that meets a federal definition and when they are not. It is not perfect, and there's lots of places where it's very hard to regulate these kinds of things. So we're trying to set sort of expectations and kind of aspirational goals for state Medicaid programs. But I would invite you to take a look at that. But I really am very, very struck by the relationship between palliative care as an approach to care, not just for people at end of life, but at all stages of life. So thank you.
So I'm Carol Blackford. I'm on the Medicare side of the House, and I would like to thank Assistant Secretary Greenlee and the Center for the opportunity to participate in the conversation today. It has been a very engaging conversation around how to think about this lifespan policy agenda for palliative care, and I'd like to echo Susie and Mike's comments that the frame for the conversation is really critical, as palliative care is often equated with hospice or end-of-life care, as we've talked about today, but palliative care is really more than that. It's an approach to providing care focused on pain and symptom management and quality of life. It's person-centered healthcare. And the key is really how to integrate that approach, that view, into the delivery of healthcare and how to create the payment and the financial incentives for providing high-quality, person-focused care in both the institutional and in the community settings. So much like Susie was talking about, the current fee-for-service structure in Medicare has defined benefits and defined payment structures, and there isn't a defined benefit category for palliative care, but rather a patchwork of reimbursement opportunities that are driven by the specific medical and clinical services that are provided for palliation and symptom management that are also covered under Medicare Part A or Part B. Now, thankfully, most payers, whether private or federally funded, have been moving away from this fee-for-service, volume-driven approach, and it's really moving towards paying for value and looking for alternatives that would better align those incentives for high-quality, person-centered healthcare, including palliative care. Now, with our aging population and the Medicare spending continuing to grow, obviously CMS and MedPAC and Congress and all of the stakeholders in this space are really focused on reforming our payment structure in a way that creates those incentives for improving quality and greater efficiency. And this is accomplished in two ways. One, by overlaying new mechanisms on top of existing payment structures, like value-based purchasing and readmission penalties, but also looking at broader delivery system reforms that have the potential to drive improvements across the healthcare setting, like accountable care organizations and payment bundling and patient-centered medical homes. Our Innovation Center, we've talked about some of the projects today in the earlier panel. They are awarding funding via Healthcare Innovation Awards and Innovation Advisor programs, and really looking towards organization and clinicians out in the field who are working towards implementing compelling ideas on how to better deliver health care and improve the care and lower the cost to our beneficiaries, particularly those beneficiaries with the highest healthcare needs. And again, we've heard a lot about that today, and there really isn't enough time to go through everything that's coming out of the Innovation Center. So I think the bigger point that I'd like to make here is that the policy window is open. And I'm sure there are many in the audience here today who feel that this is a conversation we've been having for a long time. Early in my federal career, I had the opportunity to participate in a breakthrough collaborative session on end-of-life care that Joanne Lynn facilitated. And the conversation was around encouraging palliative care in institution and community-based settings. And there were a lot of similarities and a lot of similar themes with what we talked about back then and what we've talked about today. But we are collectively moving the ball forward. The Affordable Care Act was really a game changer. It opened that policy window by including a number of really real opportunities to realign those financial incentives in a way to encourage that patient-centered and family-centered, high-quality care. So I know time is short. I'm going to stop here, but I hope everyone paid very close attention to the panel discussion this afternoon. It was really a good opportunity to highlight some of the real opportunities for reform and the real potentials to improve healthcare in meaningful ways. So, thank you.
Good afternoon, everyone. I'm Ido Banik. I'm with the Medicare Medicaid Coordination Office. First of all, thank you for having this. Thank you for having us here. We really appreciate it. All right, in 3 minutes or less. So 7 years ago, when I was 12, when I worked at the Visiting Nurse Service in New York, one of the first projects that I got, I was an in-house lawyer, was help us figure out this palliative care program. Help us figure out how we can sort of establish it, how we can get reimbursed. And of course, being a lawyer, my first thought was, well, what is it? Well, it's a philosophy. We don't pay for philosophies. How do we? Medicare doesn't pay for philosophies. Medicaid doesn't pay for philosophies. How exactly do we do this? And I don't think the organizers knew this, but I spent a lot of time working with our team at the Visiting Nurse Service of New York, really getting the structure together, having a professional corporation established, and figuring out how to sell this to managed care companies, many of whom at the time wouldn't buy it. And one of the big movements we've seen with the Affordable Care Act is this movement not into paying for philosophies, but into paying for a lot of the same things that underlie these philosophies. So at the Medicare Medicaid Coordination Office, which was established by the Affordable Care Act, we have the impetus to sort of occupy this area in between Medicare and Medicaid. Get Medicare and Medicaid better aligned, get them working better for people that have Medicare and Medicaid, but really begin to push the boundaries, not for the sake of paying for extra stuff, but for the sake of paying for the right stuff, for the sake of paying for these words that we use, self-direction, person-centered planning. A lot of the demonstrations that we're working on, as well as the Innovation Center are working on, are really meant to take the system from a place where we say, does it fit into this tranche? Does it fit? Can it be reimbursed in this way? To a system where we think more holistically about what's in the patient's best interest, and by the way, in our best interest too, as the country. So again, I've said a little about the Medicare Medicaid Coordination Office, but we're working in two major areas. One is program alignment, this sort of pushing the envelope of what Medicare and Medicaid pay for and how they work together. And the other is working with the Innovation Center through their waiver authority to do demonstrations. We have one going now in Massachusetts, we have another going in Washington, and we have a number of others that we're working on where the rules, what is payable for, can be changed, especially on the Medicare side and a little bit on the Medicaid side. Creates an incredible amount of flexibility, and we'll be able to demonstrate with the states, does this work or does this not work? We hope that this will work. So expanded telehealth, expanded home health benefits, this move away from Medicare and Medicaid having different definitions of things and sort of fighting it out, which sometimes gets in the way of patient care in the sort of the durable medical equipment world. So anyway, a lot to say. I won't say it. I appreciate the fact that you had me here, and I look forward to hearing more. Thank you all.